Hello, amazing nurses in the making. Welcome once again to Coast NCLEX, your one-stop destination for mastering nursing concepts with ease and excellence. Here, we post 2 to 3 high-yield NCLEX videos every single day, designed to sharpen your clinical reasoning, boost your exam performance, and help you think like a professional nurse. In today's interactive learning session, we will explore the vital topic, nursing care of clients with disorders of the mouth. Oral health is a mirror of overall health. And as nurses, understanding disorders such as stomatitis, gingivitis, candidiasis, mucositis, and oral cancer is essential for both prevention and holistic care. In this video, we will discuss pathophysiology, early symptoms, medical and surgical management, and priority nursing interventions. You will also learn how to provide effective oral hygiene care, manage pain and nutrition, and deliver compassionate client education, all of which are key points tested in the NCLEX and clinical practice alike. So grab your notes and stay tuned till the end, because every second here adds strength to your nursing foundation. And remember, at Coast NCLEX, we are not just preparing you to pass the exam. We are preparing you to lead with skill, empathy, and clinical excellence. Let's begin today's insightful session on disorders of the mouth. Hey friend, pause for just a sec.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Moving ahead into challenging NCLEX-style question that blends clinical reasoning with nutritional management during cancer therapy, let us look at this scenario. A client undergoing chemotherapy for Hodgkin's lymphoma develops severe mucositis with painful ulcerations of the oral cavity and difficulty swallowing. The dietitian and nurse collaborate to modify the client's meal plan. The question asks, which food items should the nurse withhold from the client's dietary tray? Here are the options to think through carefully. Option 1, tomato soup. Option 2, lime gelatin. Option 3, canned peaches. Option 4, hot coffee. Option 5, toast. Option 6, vanilla ice cream. The correct answers are Option 1, tomato soup. Option 4, hot coffee. And Option 5, toast. Let us now explore the expanded advanced rationale in depth. Chemotherapy targets rapidly dividing cells, including both cancerous and healthy epithelial cells, lining the gastrointestinal tract. This process leads to mucositis, an inflammatory and ulcerative reaction that makes the oral and gastrointestinal mucosa highly fragile. As a result, the client experiences redness, sensitivity, and pain that can worsen with inappropriate dietary choices. Thus, proper food selection is essential to minimize irritation, prevent infection, and maintain nutritional balance. Tomato soup should be withheld because its acidic nature can burn and inflame the already sensitive mucosal tissue, worsening the client's pain. Hot coffee should also be avoided since the combination of heat and acidity exacerbates inflammation and discomfort, while caffeine causes dehydration and additional dryness. Toast, being coarse and abrasive, can physically injure the ulcerated mucosa, causing bleeding and intense pain. In contrast, lime gelatin, though mildly acidic, is cool, soft, and soothing, making it easy to tolerate and helpful in maintaining hydration. Canned peaches, when soft and not an overly acidic syrup, are gentle on the mouth and easy to swallow. Vanilla ice cream, being cold and creamy, temporarily numbs oral pain and provides needed calories for healing and energy. Now transitioning into the Coast clinical insight. When mucositis develops, think cool, bland, and soft. The oral cavity behaves like a delicate surgical wound. Nurses must protect it as they would protect a healing incision. Avoiding temperature extremes, rough textures, and irritants prevents mild soreness from escalating into severe, debilitating pain that hinders nutrition and recovery. And moving onward to the Coast high-yield NCLEX Pearl, avoid foods that are acidic, spicy, salty, coarse, or hot. Examples include tomatoes, citrus fruits, vinegar, pepper, toast, and chips. Instead, encourage cool, bland, soft, non-acidic foods such as milkshakes, custards, puddings, mashed potatoes, and smoothies. Advise the client to rinse frequently with saline or sodium bicarbonate solution to keep the mouth moist and free of infection. Promote gentle oral hygiene using a soft bristled brush or sponge applicator, avoiding alcohol-based mouthwashes. Collaborate with the dietitian and oncologist to include high-calorie, high-protein foods that support mucosal healing and prevent weight loss. Lastly, here is the clinical takeaway. Mucositis is not a minor issue. It can become a serious dose-limiting side effect of chemotherapy. Effective nursing interventions such as oral care, symptom control, and dietary modification preserve nutrition, prevent infection, and help ensure treatment continuity for optimal recovery. Let us transition into our next advanced level NCLEX-style scenario, focusing on oral hygiene management for immunocompromised clients. A nurse is preparing to provide oral care for a client undergoing intensive chemotherapy who reports severe oral pain and bleeding gums. Upon careful inspection, the oral mucosa appears erythematous, ulcerated, and covered with patchy white plaques, classic signs of chemotherapy-induced mucositis. The question asks, which item should the nurse obtain to safely and effectively perform oral hygiene? Here are the options to consider carefully. Option 1, pediatric toothbrush. Option 2, battery-operated toothbrush. Option 3, sponge-tip swabs. Option 4, mint-flavored mouthwash. The correct answer is Option 3, sponge-tipped swabs. Now, let us explore the expanded advanced rationale. Clients receiving chemotherapy or radiation therapy frequently develop mucositis, an inflammatory and ulcerative process that damages the rapidly dividing epithelial cells of the oral mucosa. This makes the lining of the mouth fragile, painful, and prone to bleeding. Using a regular or even soft bristled toothbrush can cause microtears, increase bleeding, and open pathways for bacterial infection, particularly in immunocompromised or thrombocytopenic patients. Therefore, the nurse's primary goal is to promote comfort while maintaining oral hygiene without causing trauma. Sponge-tipped oral swabs are the best choice because they are gentle, absorbent, and capable of cleaning plaque and debris with minimal friction. When moistened with normal saline or a mild sodium bicarbonate solution, these swabs neutralize acidity, reduce bacterial growth, and soothe mucosal tissue, promoting healing and comfort. In contrast, battery-operated toothbrushes cause vibrations that can irritate fragile mucosa, while pediatric toothbrushes, though smaller, still have bristles that may scrape ulcerated surfaces. Mint-flavored mouthwashes, particularly those containing alcohol, further irritate, dry, and damage the mucosa, delaying recovery. Before we wrap up, here comes your Stancoast clinical insight. When mucositis turns the mouth into a wound, the nursing priority shifts from cleansing to comforting. Gentle oral care protects tissue integrity, prevents infection, and sustains healing. And finally, the Stancoast High-Yield NCLEX Pearl reminds you, always use sponge-tipped swabs or saline-moistened gauze for clients with mucositis, neutropenia, or thrombocytopenia. Avoid bristled toothbrushes and flavored mouthwashes. Encourage frequent saline or baking soda rinses every 2 to 4 hours. And collaborate with the dietitian to ensure soft, bland foods that promote recovery and maintain nutrition. Let us transition smoothly into another NCLEX-style scenario that highlights the nurse's clinical prioritization in oral hygiene management. A nurse is providing total care to a group of dependent clients in a long-term care facility. During morning hygiene rounds, the nurse must prioritize oral care based on each client's individual needs. The question asks, which client requires specialized oral care twice daily to maintain oral mucosal integrity and prevent complications? Here are the options for your consideration. Option 1, the client who has full dentures. Option 2, the client who is on fluid restrictions. Option 3, the client who is on a low-residue diet. Option 4, the client who sucks on ice chips. The correct answer is Option 2, the client who is on fluid restrictions. Now, let us explore the advanced expanded rationale in detail. Clients who are placed on fluid restrictions are particularly vulnerable to developing xerostomia or dry mouth. This occurs because limited fluid intake directly reduces systemic hydration and thereby decreases saliva secretion. Saliva serves as the body's natural cleansing and protective mechanism. It lubricates the oral cavity, removes debris, neutralizes acids, and suppresses bacterial growth. When saliva production decreases, the oral tissues become dry and sticky, creating an environment where plaque, bacteria, and fungi such as Candida albicans can thrive. As a result, these clients are at high risk for mucosal breakdown, halitosis, and painful ulcerations. Therefore, nurses must provide specialized oral care at least twice daily, using gentle, non-irritating methods such as sponge-tipped swabs moistened with saline, application of water-based moisturizers, and bicarbonate rinses instead of alcohol-containing mouthwashes. These interventions restore comfort, maintain mucosal integrity, and significantly reduce infection risk, especially for clients who cannot drink freely. Furthermore, consistent and compassionate oral care in this group does more than maintain comfort. It prevents serious complications such as aspiration pneumonia, which can develop when oral pathogens migrate to the lower respiratory tract. Hence, this client's oral care plan should always take top priority during nursing rounds. Moving on to understand why the remaining options are incorrect. Option 1, the client who has full dentures, does not necessarily require specialized oral care unless irritation, infection, or poor fit causes mucosal damage. Dentures can be removed, cleaned, and soaked overnight while the oral mucosa is gently wiped, but hydration and saliva secretion remain unaffected. Next, option 3, the client on a low-residue diet has dietary changes that primarily affect the gastrointestinal tract by reducing bowel volume, not the oral mucosa or saliva flow. Therefore, routine oral hygiene is sufficient in this case. Finally, option 4, the client who sucks on ice chips actually benefits from temporary oral moisture and comfort, as ice chips help alleviate dryness rather than worsening it. Now transitioning to a key professional reflection for deeper understanding. Stand-Coast Clinical Insight. When water is limited, a nurse's compassion becomes the hydration the mouth depends on. Gentle, frequent oral care restores comfort, prevents infection, and safeguards dignity, one swab at a time. Let us now connect this with an NCLEX-focused learning takeaway. Stand-Coast High-Yield NCLEX Pearl. Clients who are on fluid restrictions, oxygen therapy, anticholinergic medications, or diuretics often have reduced saliva flow. They require frequent oral care using moist swabs and non-alcohol-based rinses. Avoid glycerin or alcohol-containing mouthwashes, as these worsen dryness and mucosal irritation. Encourage saline or bicarbonate rinses every 2 to 4 hours to maintain oral health. Consistent oral care prevents mucositis, candidiasis, and aspiration pneumonia, thereby promoting overall comfort and safety. Let us now move into another advanced level NCLEX-style question that highlights safe and hygienic denture care, a vital aspect of maintaining oral health and client dignity, especially among elderly clients who depend on nursing support. A nurse is preparing to perform denture care for an elderly client who is partially dependent on nursing assistance. Which techniques should the nurse implement to ensure safety, infection control, and proper denture maintenance? Select all that apply. Here are the options to consider. Option 1, using hot water while brushing and rinsing the dentures. Option 2, holding the dentures over a basin of water or a soft towel. Option 3, applying solvent to remove oral adhesive from the dentures. Option 4, placing the dentures in a clean, dry container after brushing. Option 5, donning clean gloves before taking dentures from the client's mouth. Option 6, removing the lower plate from the mouth by turning it to a slight angle. The correct answers are Option 2, Option 5, and Option 6. To understand this more deeply, let us carefully examine each option and its rationale. Beginning with Option 2, holding the dentures over a basin of water or a soft towel. Correct. This technique ensures that if the dentures accidentally slip during cleaning, the impact will be cushioned, preventing cracks or fractures. Dentures are delicate and expensive to replace, so holding them over a towel or water basin is a fundamental safety measure that protects both the prosthesis and the client's comfort. Moving forward to Option 5, donning clean gloves before taking dentures from the client's mouth. Correct. Wearing gloves is a key component of standard precautions. Since contact with the saliva and mucous membranes carries the risk of transmitting microorganisms, gloves serve as an essential barrier. maintaining hygiene and professional infection control during oral care procedures. Next, let us review option 6, removing the lower plate from the mouth by turning it to a slight angle. Correct. Lower dentures rely on suction and muscle tension to stay in place. By gently rotating the plate at a slight angle, the nurse breaks the suction seal safely, minimizing gum trauma, discomfort, and the risk of tissue injury. Now, shifting to the incorrect options, option 1, using hot water while brushing and rinsing the dentures. Incorrect. Hot water can warp or deform the acrylic material of dentures, resulting in poor fit and potential mucosal sores. Lukewarm water is always the correct choice to preserve shape and comfort. Similarly, option 3, applying solvent to remove oral adhesive from the dentures. Incorrect. This approach is not recommended. Adhesive residues dissolve easily with warm water and gentle brushing, while solvents can erode the denture surface, causing irritation and increasing the risk of bacterial growth. Lastly, option 4, placing the dentures in a clean, dry container after brushing. Incorrect. Dentures must always be kept moist when not in use. Storing them dry can cause the acrylic to shrink and crack, resulting in discomfort and poor fit. They should be stored in water or a proper denture soaking solution to maintain their integrity and hydration. Now transitioning into the Stand-Coast clinical insight. When providing denture care, a nurse's gentle hands protect more than plastic. They preserve a person's confidence, comfort, and dignity. Handle dentures safely, clean them properly, and always maintain infection control. Now moving into the Stand-Coast high-yield NCLEX Pearl. Always wear gloves when handling dentures to maintain infection control. Never use hot water. Always use lukewarm water to prevent deformation. Store dentures in water or a soaking solution, never dry. Hold dentures over a towel or water basin to avoid breakage. Remove lower dentures gently by turning them at an angle to release suction safely. Let us now shift our focus to another critical aspect of nursing safety. When the nurse is brushing an unconscious client's teeth, how should the client be positioned to ensure both safety and effective oral care? Here are the options to consider carefully. Option 1, supine with the head elevated. Option 2, side lying with the head lowered. Option 3, in Trendelenburg's position with the head slightly raised. And option 4, in a dorsal recumbent position with the head elevated. The correct answer is option 2, side lying with the head lowered. Now, let us explore the rationale behind this essential nursing intervention. When providing oral hygiene for an unconscious client, the safest and most effective position is side lying with the head slightly lowered. This position uses gravity as an ally, allowing secretions, toothpaste, and rinse fluids to drain out of the mouth rather than pool at the back of the throat. Because an unconscious client lacks protective airway reflexes such as coughing and swallowing, any accumulated fluid in the oropharynx can easily enter the airway and lead to aspiration pneumonia or airway obstruction. Tilting the head toward the mattress promotes outward drainage of saliva and oral fluids, minimizing the risk of aspiration and enhancing both safety and comfort. The nurse should always have suction equipment ready, use small amounts of water, and support the client's head gently to maintain airway protection and proper alignment throughout the procedure. Moving on to the incorrect choices, option 1, supine with the head elevated is inappropriate because, although it supports breathing for conscious clients, it allows fluids to pool at the back of the throat in an unconscious client, thereby heightening the risk of aspiration. Similarly, option 3, in Trendelenburg's position with the head slightly raised is unsafe as this position tilts the head below the level of the feet, directing fluids toward the trachea and making aspiration more likely. This position is reserved for clients in shock to improve venous return, not for oral care. Lastly, option 4, in a dorsal recumbent position, with the head elevated remains unsuitable because even with a slightly raised head, secretions can still accumulate in the throat, making it dangerous for oral hygiene in an unconscious client. Now transitioning into the Stand-Coast clinical insight. During oral care for an unconscious client, gravity becomes your greatest safety tool. Turning the head to the side transforms a risky procedure into a life-saving one, preventing secretions from silently slipping into the lungs. Now, here comes your Stand-Coast high-yield NCLEX Pearl. Always position the client side-lying with the head slightly lowered during oral care. Keep suction equipment ready for immediate use. Use soft bristled brushes or foam swabs moistened with minimal water or saline. Avoid large amounts of liquid and never pour fluids directly into the mouth. Finally, apply a water-soluble lubricant to keep the lips moist and prevent tissue cracking. Hold on. Don't skip this.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now move into this next advanced level NCLEX-style question that highlights both clinical observation and microbiological understanding. A client who has been taking a broad-spectrum antibiotic for the past 2 weeks visits the clinic complaining of a sore mouth, burning tongue, and difficulty eating and swallowing. The nurse suspects oral candidiasis, commonly known as thrush. The question asks, which findings should the nurse expect when inspecting the client's oral cavity? Here are the options to consider carefully. Option 1, clear, shiny, domed vesicles on the tongue. Option 2, red, ulcerated patches along the gum margin. Option 3, white, curd-like plaques throughout the mouth and tongue. Option 4, dark brown, flat lesions on the soft palate and oropharynx. The correct answer is option 3, white, curd-like plaques throughout the mouth and tongue. Now, let us unfold the rationale behind this finding. When a client on long-term antibiotic therapy reports soreness and difficulty swallowing, along with white plaques in the mouth, oral candidiasis should be highly suspected. This fungal infection is caused by Candida albicans, a yeast that normally exists harmlessly within the oral cavity and gastrointestinal tract. However, when broad-spectrum antibiotics are used for extended periods, they disrupt the normal bacterial flora that suppresses fungal growth. As a result, Candida overgrows and causes characteristic mucosal lesions. Clinically, oral thrush appears as creamy white or curd-like patches that resemble milk curds on the tongue, buccal mucosa, and palate. When these plaques are gently wiped away, they reveal raw, erythematous, or bleeding mucosa, a hallmark that distinguishes thrush from other oral lesions. Clients often describe a burning sensation, altered taste, or pain during swallowing. This condition is particularly common among immunocompromised individuals such as those with HIV/AIDS, cancer, diabetes mellitus, or those receiving corticosteroids or chemotherapy. Diagnostic confirmation can be obtained using a potassium hydroxide, KOH, smear, or fungal culture. Nursing care focuses on maintaining oral hygiene, encouraging rinsing after inhaled corticosteroid use, and administering prescribed antifungal therapy such as nystatin suspension or clotrimazole troches. In severe or systemic cases, oral fluconazole is indicated. Shifting our focus to the incorrect choices, option 1, clear, shiny, domed vesicles on the tongue, is more typical of herpes simplex virus, HSV1, infection, rather than fungal disease. These vesicles rupture to form painful shallow ulcers, usually seen on the lips or hard palate. Moving to option 2, red, ulcerated patches along the gum margin. This pattern is characteristic of gingivitis, a bacterial infection caused by plaque accumulation along the gum line. It causes gum redness and bleeding but lacks the distinctive white coating of candidiasis. Finally, option 4, dark brown, flat lesions on the soft palate and oropharynx, points toward Kaposi's sarcoma, a vascular tumor associated with advanced HIV infection. These lesions are non-scrappable, purple-brown, or dark spots, and do not resemble the removable white plaques of oral thrush. Transitioning to a stand-coast clinical insight, oral thrush often hides behind a simple sore mouth until it interferes with eating and swallowing. Recognizing those creamy white curds early allows the nurse to act fast, restoring comfort and preventing deeper fungal invasion. And now for your quick recall key, stand-coast high-yield NCLEX Pearl. Long-term antibiotics, corticosteroids, and immunosuppression encourage fungal overgrowth. White plaques that wipe away leaving red mucosa are the hallmark sign of oral candidiasis. Clients using inhaled steroids should always rinse and spit after each use. Avoid mouthwashes containing alcohol and maintain meticulous oral hygiene. Administer prescribed topical antifungals promptly, and document all oral changes carefully. Let us now move forward into another advanced level NCLEX-style question that focuses on understanding opportunistic infections and their origin. A client who recently developed white, curd-like plaques on the tongue and buccal mucosa asked the nurse, "Where did this infection come from?" The question tests not only your microbiological knowledge, but also your ability to educate clients effectively. The options are as follows. Option A, transferring bacteria from unclean dental instrument. Option B, having an overgrowth of normal mouth organisms. Option C, inhaling moist droplets when someone sneezed. Option D, using someone's unwashed eating utensils. The correct answer is option B, having an overgrowth of normal mouth organisms. Now, let us unfold the rationale behind this important concept. Oral candidiasis, also known as thrush, is a fungal infection caused by Candida albicans, an opportunistic yeast that normally lives in the mouth, gastrointestinal tract, and vagina as part of the body's natural flora. Under normal immune conditions, these microorganisms stay balanced and harmless. However, when the equilibrium is disrupted, such as through the use of broad-spectrum antibiotics, corticosteroid therapy, uncontrolled diabetes mellitus, immunosuppression, as seen in HIV or chemotherapy, or poor oral hygiene, Candida can multiply excessively and invade the mucous membranes. This overgrowth leads to the formation of characteristic creamy white plaques that can be wiped off, often leaving red or bleeding mucosa underneath. Because Candida albicans originates from within the body's normal flora, oral candidiasis is not typically transmitted externally, but develops endogenously. It is, therefore, classified as an opportunistic infection, thriving when the host's defenses are compromised. Transitioning to the incorrect options, let us analyze why they do not fit this clinical scenario. Option A, which suggests transferring bacteria from unclean dental instruments, is incorrect because candidiasis is fungal in nature, not bacterial. Moreover, dental equipment is routinely sterilized according to strict infection control standards, making this mode of transmission extremely unlikely. Moving on to option C, inhaling moist droplets when someone sneezed is also incorrect, since Candida albicans is not spread through respiratory droplets. Unlike viral infections, fungal spores are not airborne in this context. Finally, option D, using someone's unwashed eating utensils, is not a common route for acquiring oral thrush. While oral contact could theoretically transfer fungal organisms, immunocompetent individuals rarely develop candidiasis this way. Instead, the infection most often arises from internal imbalance rather than external exposure. Now, before we wrap up this concept, let us take a moment to focus on a deeper clinical connection that nurses must always remember. Stand-coast clinical insight. Oral thrush often does not come from the outside world, it blooms from within. When antibiotics silence the mouth's natural bacteria, Candida seizes the stage. Recognizing that this infection is self-originating helps nurses focus on restoring microbial balance rather than blaming contamination. And before we move on to the next question, let us highlight a few quick, high-yield takeaways that will help you retain this concept for your exams. Stand-coast, high-yield, NCLEX Pearl. Remember these crucial exam points. Candida albicans is an opportunistic fungus and part of the normal flora. Common triggers include prolonged antibiotic use, corticosteroids, diabetes, and immunosuppression. White, curd-like plaques that wipe off are the hallmark sign of thrush. Always teach clients to rinse after using inhaled corticosteroids, maintain good oral hygiene, and take antifungal medications like nystatin suspension or fluconazole as prescribed. Let us smoothly transition into our next advanced level NCLEX-style question that focuses on antifungal therapy and effective client education. A nurse is educating a client who has been prescribed nystatin oral suspension for the treatment of oropharyngeal candidiasis, also known as thrush. Which instruction by the nurse demonstrates the most accurate teaching regarding the administration of this medication? Here are the options. Option A, drink the medication through a straw to protect the teeth. Option B, dilute the medication with cold water to reduce irritation. Option C, swish the medication thoroughly in the mouth, then swallow it. Option D, brush the teeth immediately after taking the medication. The correct answer is option C, swish the medication thoroughly in the mouth, then swallow it. Now, let us explore the expanded advanced rationale Nystatin oral suspension is an antifungal medication specifically designed to treat candida infections of the mouth and throat. Because it is poorly absorbed from the gastrointestinal tract, its effectiveness relies on direct contact with fungal organisms on mucosal surfaces. Therefore, the client should be instructed to swish the medication slowly and thoroughly in the mouth, ensuring contact with all areas including the tongue, gums, cheeks, and palate before swallowing. This technique allows maximum exposure of the antifungal to infected tissues, while swallowing helps treat possible fungal spread to the oropharynx and upper gastrointestinal tract. Additionally, clients should avoid eating, drinking, or rinsing their mouth for at least 30 minutes after administration to allow optimal mucosal contact. It is best to take the medication after meals and oral hygiene to maintain cleanliness and prolong exposure time. When we look at the incorrect options, it becomes clearer why they are unsuitable, starting with option A, drink the medication through a straw to protect the teeth. This is incorrect because nystatin does not stain or damage enamel. Using a straw would bypass the oral mucosa, reducing contact and therapeutic action. Moving to option B, dilute the medication with cold water. This is also incorrect since dilution decreases the concentration of the active drug, reducing its antifungal potency and effectiveness. Lastly, option D, brush the teeth immediately after taking the medication, is incorrect because brushing afterward removes the medication from mucosal surfaces, reducing contact time and thus its effectiveness. The client should perform oral hygiene before, not after, taking the dose. Transitioning now to Stancoast clinical insight. Think of nystatin as a topical antifungal working inside the mouth. Its effectiveness depends not on absorption but on contact. The longer it stays on the mucosa, the stronger its antifungal action. Swish it slowly, savor the swirl, and swallow to protect the throat. Now, here comes your Stancoast high-yield NCLEX pearl. Mechanism of action. Nystatin binds to ergosterol in fungal cell membranes, leading to leakage of cellular contents and fungal cell death. Key nursing instructions. Swish and swallow without dilution, avoid eating or drinking for 30 minutes after use, and administer following meals and oral care for maximum mucosal coverage. Prevention. Tip. Encourage clients who use inhaled corticosteroids to rinse their mouth after inhalation and maintain excellent oral hygiene to prevent recurrent candida infections. Before we begin, I want to share something that has already helped more than 100,000 nursing students achieve success.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Moving forward with our next challenging NCLEX-style scenario, let us focus on an important topic related to oncology and client health history interpretation. A 70-year-old client is referred for evaluation of suspected mouth cancer following a routine dental checkup. When the nurse reviews the client's medical history, which contributing factor is most likely to increase this client's risk for developing oral cancer? Here are the options to think through carefully. Option A, the client smoked marijuana occasionally as a teenager. Option B, the client has used smokeless tobacco throughout adulthood. Option C, the client has had occupational exposure to asbestos as a construction worker. Option D, the client has poor dental hygiene with several decayed teeth. The correct answer is option B, the client has used smokeless tobacco throughout adulthood. To understand why this is the most accurate choice, let us explore the expanded rationale in depth. Oral cancer, most often in the form of squamous cell carcinoma, results from repeated exposure of the oral mucosa to carcinogenic substances and chronic irritation over time. Major predisposing factors include prolonged tobacco use, whether smoked or smokeless, heavy alcohol consumption, persistent friction from dental appliances, and infection with human papillomavirus. Among these, smokeless tobacco poses a particularly severe risk because carcinogenic nitrosamines are directly absorbed through the oral mucosa. This chronic chemical exposure triggers inflammation, cellular mutations, and precancerous changes such as leukoplakia, which may eventually progress to malignancy. It is common for these cancers to develop precisely at the sites where clients have habitually held chewing tobacco or snuff for many years. Transitioning to the incorrect alternatives, option A, occasional marijuana use during adolescence, is not a significant cause of oral cancer later in life, although frequent marijuana smoking may contribute to respiratory or head and neck malignancies. Limited teenage experimentation lacks the chronicity required for carcinogenesis. Option C, asbestos exposure, is linked to lung cancers such as mesothelioma and bronchogenic carcinoma, not oral malignancies, because the fibers damage pleural rather than mucosal tissues. Option D, poor dental hygiene and decayed teeth, may worsen local irritation and mask early lesions, but do not directly initiate cancerous growth. Transitioning into a Stan-Coast clinical insight. Oral cancer often whispers before it roars, beginning as a painless red or white patch that patients overlook until it ulcerates or bleeds. Vigilant nurses can catch these early signs during routine oral checks, especially in clients with a chronic habit of chewing tobacco or using alcohol. Before we conclude, let us highlight some crucial exam points. Stan-Coast, high-yield NCLEX pearl. Common sites of oral cancer include the tongue's lateral borders, the floor of the mouth, and the lower lip. High risk factors: smokeless or smoked tobacco, heavy alcohol intake, human papillomavirus infection, chronic mechanical irritation, and excessive sun exposure. For lip cancer. Early warning indicators: persistent ulcers, leukoplakia, erythroplakia, and unexplained bleeding in the mouth. Key nursing actions: promote tobacco and alcohol cessation, educate on self-inspection of the oral cavity, and ensure prompt evaluation of any oral lesion lasting beyond 2 weeks. Let us now transition into another clinically important NCLEX-style scenario that focuses on post-operative care following oral cancer surgery. After surgical excision of an oral cancer lesion, a client is scheduled to receive post-operative radiation therapy at home. During discharge planning, the nurse must identify which interventions take priority in the immediate post-operative period. Here are the options to analyze carefully. Option A, position the client with the head of the bed flat. Option B, assess the client's ability to speak clearly. Option C, irrigate the client's mouth when fully awake and alert. Option D, observe the client's ability to swallow. Option E, provide ice chips as tolerated. Option F, watch for signs of depression. The correct answers are options B, C, D, and F. To explain this in detail, the rationale focuses on 3 fundamental post-operative goals: maintaining a patent airway, promoting nutrition and hydration, and supporting communication and psychological well-being. Since post-operative edema and pain can compromise the airway, the nurse must never position the client flat. Option A is incorrect because lying flat may obstruct the airway and increase aspiration risk. Instead, the head of the bed should be elevated 30 to 45 degrees to enhance breathing, allow secretion drainage, and minimize facial swelling. Next, assessing the client's ability to speak clearly, as indicated in option B, is a top priority. Surgery involving the tongue, mandible, or soft palate may impair speech. Early evaluation helps determine the need for communication aids such as writing boards or charts, which not only reduce anxiety, but also promote safety by allowing clients to express pain or discomfort effectively. Following that, option C, irrigating the mouth once the client is fully awake and alert, is an essential infection prevention measure. Gentle rinsing with sterile saline or prescribed solutions clears debris, clots, and bacteria, promoting faster wound healing and maintaining mucosal moisture. Nurses must take care to avoid traumatizing the surgical site or sutures during this process. In option D, observing the client's ability to swallow is critical before offering any oral intake. Post-operative edema, nerve damage, or reduced sensation can impair swallowing, increasing the danger of aspiration pneumonia. Signs such as coughing, drooling, or difficulty handling secretions should prompt referral to a speech or swallowing therapist for further assessment. While option E suggests providing ice chips, this is not advisable. Temperature extremes, whether hot or cold, can irritate or damage healing tissue, delaying recovery. Room temperature fluids or gentle oral rinses are safer alternatives. Lastly, Option F emphasizes the need to monitor for depression. Clients recovering from oral cancer surgery often face major emotional challenges, including altered appearance, impaired communication, and social withdrawal. Early identification of depressive symptoms allows for prompt counseling, emotional support, and improved treatment adherence. Now, before we conclude this scenario, let us pause for an important reflection. Stancoast Clinical Insight. After oral cancer surgery, healing the wound is only half the journey. The nurse's role is to restore the client's dignity, communication, and confidence. Every small step toward comfort and self-expression contributes to holistic recovery. And as we wrap up, here comes your NCLEX power tip to remember. Stancoast High Yield NCLEX Pearl. Always elevate the head of the bed to prevent airway obstruction. Assess speech and swallowing before offering oral intake. Perform gentle sterile oral irrigation to prevent infection. Avoid hot, spicy, or cold foods until healing is complete. Provide psychological and emotional support to address depression and promote adaptation. Let us smoothly move into our next advanced NCLEX-style question, which focuses on discharge education following oral cancer treatment and radiation therapy. As part of discharge teaching, the nurse prepares a client who has undergone surgical excision for oral cancer and is scheduled to begin external beam radiation therapy to the head and neck the following week. The nurse must determine which potential side effects and self-care topics should be included in the discharge education plan. The options are as follows: alopecia, pale skin at the site, restlessness, stomatitis, xerostomia, and confusion. The correct answers are alopecia, stomatitis, and xerostomia. Now, let us carefully go through the expanded rationale to understand why these are correct and what clinical reasoning supports each choice. Radiation therapy to the head and neck targets residual cancer cells, but inevitably affects healthy, rapidly dividing tissues, particularly the skin, mucosa, and salivary glands. Beginning with alopecia, this occurs because radiation destroys the hair follicle matrix in the treatment field. Hair loss may be temporary or permanent, depending on the dosage and exposure area. It usually begins 2 to 3 weeks after therapy starts. Nurses should teach clients gentle hair care, avoidance of heat styling or chemicals, and provide emotional support for body image changes. Moving to pale skin at the site, this option is incorrect because radiation typically causes redness, warmth, and irritation rather than pallor. The affected skin may later become dry, flaky, and hyperpigmented. Clients should avoid scratching, applying perfumes or lotions not approved by the oncologist, and wear loose, soft clothing over the irradiated area. Next, regarding restlessness, this is not a common radiation side effect. Instead, clients usually experience fatigue due to increased cellular repair demands and cytokine release. Nurses should promote adequate rest, balanced nutrition, and gentle activity as tolerated. Turning to stomatitis, this is one of the hallmark side effects of head and neck radiation therapy. It involves painful inflammation and ulceration of the mouth and throat lining, leading to difficulty eating or swallowing. Nursing education includes using soft bristled toothbrushes, avoiding spicy foods and alcohol-based mouthwashes, performing frequent saline or sodium bicarbonate rinses, and reporting early signs of mucosal pain to prevent dehydration or infection. Now for xerostomia, or dry mouth, this results from damage to the salivary glands within the radiation field. Clients may experience thick saliva, taste changes, or increased dental caries. Teaching includes sipping water frequently, using sugar-free gum or lozenges, and using saliva substitutes to protect oral health. Lastly, confusion is incorrect, as cognitive effects are not expected unless the brain itself is irradiated or metastasis is present. In addition to these, clients may also experience mild nausea, poor appetite, or fatigue due to the body's response to radiation. Thorough teaching empowers the client to anticipate and manage side effects, improving adherence and emotional readiness for therapy. Before we wrap up this scenario, let us pause for a reflective moment to connect clinical understanding with compassionate nursing care. Stancoast Clinical Insight. Radiation therapy heals invisibly, yet impacts visibly. The skin, mouth, and spirit require as much care as the cancer itself. Early teaching transforms side effects into manageable milestones rather than unexpected crises. Now moving to Stancoast High Yield NCLEX Pearl. Expect erythema, fatigue, alopecia, stomatitis, and xerostomia. Avoid applying heat, friction, or chemicals on the irradiated skin. Encourage soft, bland foods and meticulous oral hygiene. Promote hydration and the use of saliva substitutes. Teach clients that balanced nutrition, adequate rest, and emotional support are essential components of recovery. Let us gracefully transition into our next advanced level NCLEX-style question that explores infection control and client education during a routine gynecologic examination. During this visit, the client casually mentions having a recurrent cold sore on the mouth, which they identify as being caused by herpes simplex type 1, also known as HSV1. After discussing transmission and management, the nurse evaluates the client's understanding. Which statement made by the client indicates that further teaching is required? Here are the options to consider. Option 1, my cold sore is caused by a virus. Option 2, I got this by kissing someone who also has one. Option 3, I've been under a lot of stress lately. Option 4, the sores can only form on the lips. The correct answer is option 4, the sores can only form on the lips. Now, let us explore the expanded rationale in depth. Herpes simplex virus type 1, HSV1, is a lifelong, highly contagious viral infection that mainly affects the oral and perioral regions, but may extend to nearby areas such as the cheeks, nose, or chin. The virus typically enters through mucous membranes or small skin breaks and remains dormant in the trigeminal nerve ganglia after the first infection. Over time, HSV1 reactivates in response to triggers like emotional stress, fever, sunlight, menstruation, or immune suppression, leading to recurrent outbreaks of painful vesicles. The client's statement, "The sores can only form on the lips," reveals a gap in understanding. Although the lips are the most common site, HSV1 lesions can appear anywhere in the trigeminal nerve distribution, including the nose, cheeks, chin, or oral mucosa. In some cases, HSV1 can even infect the genital region through oral genital contact, demonstrating its potential to spread beyond the mouth area. Lesions typically start as small, grouped vesicles on a red base, which rupture, ooze, and crust within 7 to 10 days. Pain, tingling, or burning sensations often appear before the lesions erupt. The incubation period ranges from 2 to 12 days, and transmission occurs through direct contact with saliva, secretions, or vesicular fluid, even when no visible sores are present. Because of this, clients should avoid kissing, sharing personal items like utensils, and engaging in oral contact during outbreaks. Hand hygiene is critical to prevent self-spread to other body parts, especially the eyes, which can cause herpetic keratitis. Although HSV1 cannot be cured, antiviral medications such as Acyclovir, Valacyclovir, or Famciclovir help lessen symptoms, speed healing, and reduce viral shedding. Supportive measures include keeping the area clean, avoiding acidic or spicy foods that can sting the lesions, staying hydrated, and using topical anesthetics for relief. Now, let us analyze each option for better clarity. Option 1, my cold sore is caused by a virus, demonstrates correct understanding, since HSV1 is indeed a viral infection and not bacterial. Therefore, antibiotics are ineffective. Option 2, I got this by kissing someone who also has one, is also correct because HSV1 spreads through direct contact with saliva or secretions, especially during an active outbreak. Option 3, I have been under a lot of stress lately, reflects an accurate understanding as stress is one of the most common reactivation triggers. Option 4, the sores can only form on the lips, however, is incorrect, as HSV1 can appear on multiple facial or oral regions and may even spread through contact to new areas. This statement indicates that additional teaching is required to reinforce awareness about potential spread and prevention. Transitioning into the STANCOAST, clinical insight. Herpes simplex may sleep within the nerves, but it awakens with life's stress, reminding us that health is not merely the absence of disease, but the balance of body and mind. Now moving into the Stancoast high-yield NCLEX pearl, HSV1, spreads through direct contact during viral shedding. Always remember, lesions are not confined to the lips. They may involve the nose, cheeks, oral mucosa, or even the eyes. Triggers like stress, fever, or sunlight often cause recurrences. Prioritize strict hand hygiene. Avoid touching open sores, and if contact occurs, wash hands immediately. Antiviral therapy reduces both duration and transmission risk, making patient education essential for effective long-term management. Let us seamlessly transition into our next advanced level V-style question, which explores the pharmacologic management of viral infections and the importance of patient understanding during discharge teaching. The nurse is educating a client diagnosed with recurrent herpes simplex virus type 1, HSV1, infection, who has been prescribed Acyclovir, also known as Zovirax. During this teaching session, the nurse evaluates the client's understanding by asking which statement best reflects correct knowledge about the purpose of the prescribed medication. Here are the options for consideration. Option 1. I know that this drug will kill all the virus causing the lesion. Option 2. The drug shortens the duration of an outbreak. Option 3. The drug prevents future outbreaks from occurring. Option 4. I'll need to take the drug daily for the rest of my life. The correct answer is Option 2. The drug shortens the duration of an outbreak. Now, let us move through the expanded rationale to deepen our understanding. Acyclovir, Zovirax, is a potent antiviral medication that acts by inhibiting viral DNA polymerase, an enzyme vital for viral replication. This means that the drug only works during the active replication phase of the herpes simplex virus, not during the dormant stage when the virus lies hidden within the sensory nerve ganglia. The therapeutic goal of Acyclovir is to reduce viral replication, shorten the outbreak duration, lessen the severity of symptoms, and minimize viral shedding, which consequently reduces the risk of transmission. However, it does not cure the infection or eradicate the virus completely. The herpes simplex virus remains dormant in the trigeminal or sacral nerve ganglia and can reactivate under specific triggers such as stress, fever, ultraviolet exposure, menstruation, or immunosuppression. Because of this viral latency, herpes infections are lifelong and recurrent in nature. When Acyclovir is administered promptly at the onset of prodromal symptoms like tingling, burning, or itching, it can significantly shorten the course of the outbreak and promote faster healing of the lesions. Depending on the clinical severity, the medication may be administered orally, topically, or intravenously. For typical recurrent episodes, oral Acyclovir is prescribed for 7 to 10 days, while clients experiencing frequent or severe recurrences may be advised to use suppressive therapy. To summarize the mechanism, Acyclovir works by targeting the viral DNA polymerase enzyme, preventing the virus from multiplying further. However, it cannot affect viral DNA that already lies dormant in the nerve cells. Therefore, it is essential to educate clients that Acyclovir controls the infection but does not provide a permanent cure. Preventive measures such as maintaining good hand hygiene, avoiding direct contact with active lesions, managing stress, and initiating therapy at the first sign of recurrence are key to minimizing transmission and recurrence. Now, let us evaluate why the other options are incorrect. To begin with, Option 1, I know that this drug will kill all the virus causing the lesion, is incorrect because Acyclovir does not kill or eradicate the herpes virus. It only suppresses viral activity during replication. The virus continues to reside within the nerve ganglia in a latent state, beyond the reach of the medication. Next, Option 3, the drug prevents future outbreaks from occurring, is also inaccurate. Acyclovir cannot permanently prevent future outbreaks. However, when taken daily as suppressive therapy, it may reduce both the frequency and intensity of recurrences, yet it does not eliminate them entirely. Finally, Option 4, I'll need to take the drug daily for the rest of my life, is a misconception. Continuous lifelong therapy is unnecessary for most clients and is only considered for immunocompromised individuals or those who experience frequent, severe recurrences. Before we conclude, let us smoothly transition into a reflective takeaway that blends science with nursing wisdom. Transitioning to deeper understanding. Stancoast Clinical Insight. Herpes simplex teaches a lifelong lesson in viral latency. What sleeps within the nerves awakens under stress. The nurse's role is to transform this knowledge into prevention, not panic, through teaching and empathy. And finally, moving toward mastery. Stancoast High-Yield NCLEX Pearl. Acyclovir halts viral replication but does not cure herpes. Initiate therapy promptly at the earliest sign of recurrence for maximum benefit. Educate clients about managing triggers such as stress and sunlight, reinforce the importance of hand hygiene, and emphasize avoiding contact during active lesions. Remember, recurrence is possible, but timely antiviral therapy significantly reduces both symptom duration and transmission risk. Thank you for watching. We will see you in next video.